Yes, sir. We are live now.
A very good evening to all our, the delegates for today's no thrombosis program. We are very glad and very happy that this is our 41st program, 41 program. Since from last 2 years we are consistently conducting the no thrombosis program, and is completely dedicated to all our and interventional cardiologists. So that also this is one of our achievements of no thrombosis program, where we were received the most engaging scientific platform in India award also we have received. So once again, thanks to all our delegates, with your interest and with your support, it is going to possible. So that's why thank you once again for all our delegates. So again, our course director, none other than Dr. Shri Shrivat sir, is our course director for our today's no thrombosis program. Thank you, sir. Sir is associated with no thrombosis program since the launch of no thrombosis. So thank you, sir. Thank you so much from behalf of Emcure. And sir, really the introduction, sir, Shri Shrivat sir, everyone knows what Shri sir. And sir is presently as a director in Cath Lab and Ruby Hall in Pune. And sir, he is also, he is a conventional and national international council of India CSI 2004-2006. He is also a past president of CSI 2017. Welcome, sir. Welcome to the program. And the next moderator is Dr. Girish B. Sundani, sir. He is the director Cath Lab in Senior Interventional Cardiologist from Apollo Hospital, Bangalore. Dr. Noshisandhi sir performed more than 4,000 angiograms through femoral and radial and ulcer approach, and about 1,600 angioplasties, both coronary and peripheral. So first cardiologist to impact, absorb stent in private healthcare sector in the state of Karnataka. First cardiologist to implant MRI, compatible AICD system in the state of Karnataka. First cardiologist to implant, tapering coronary stent in the state of Karnataka. So once again, from behalf of Emcure, welcome, sir, for the program. And our next moderator is Dr. D. Prabhakar sir. Dr. D. Prabhakar sir is treasurer of CSI 2022 in Chennai. So Dr. Prabhakar sir is a senior consultant international cardiologist and associated with Apollo First Med Hospital and Ashwin Clinic, Chennai. Sir is also assistant professor of cardiologist in Madras Medical College, Chennai during 1988 to 2002. Participated in international and national conferences as a faculty, and also participated in many landmark trials. So from behalf of Emcure, sir, welcome to Prabhakar sir. Thank you, sir. Today's our first speaker is Dr. Rahul R. Trimuki. Sir, he is from actually Ahmednagar. Sir, he has completed MBBS in cardiology. Sir, he is very keen interest in interventional cardiologist, and he is a consultant interventional cardiologist in Trimuki Heart and Chest Super Specialty Hospital from Ahmednagar. Welcome, sir, for today's program. And today's second speaker is Dr. Suchit B. Mahali. Dr. Suchit Mahali is presently working as interventional cardiologist in Mumbai, participated in national and international conference, and specialty in coronary angiography and coronary angioplasty. Welcome to Dr. Suchit. So with this, as per our agenda, we will go with the first. We'll have some, the message from our course director, Dr. M.S. Shrivat sir. So over to you, sir. Over to you, sir.
Mr. Ravi will start with Dr. Rahul.
Yes, sir. So I request Dr. Rahul Trimuki, sir, please share your presentation, sir.
Yes. Good evening, sir.
Good evening, sir. Good evening.
Yeah. So today I will discussing the heterogenic coronary dissection at rural setup or the peripheral center. The catheter-induced coronary dissection, the incidence is less than 0.1%. The risk factor for the dissection is a atherosclerotic plaque at osteoproximal part of coronaries, use of amplat-shaped catheters or deep-sitting catheters in the coronary arteries, or the vigorous contrast injections, or the catheterization or the angioplasties in the acute myocardial infarction conditions. So here is the classification of coronary artery dissections. The type A, there is a luminal haziness in the lumen with no persistence of dye. The type B is a linear dissections or the double lumen with no persistence of dye. The type C is a extraluminal cap with persistence of dye. The type D is a spiral dissection with contrast remaining into the false lumen. The type E is a dissection with persistent filling defects in the coronary lumen, and the type F is a dissection that leads to the acute vessel closures and the no distal antegrade flow. So my patient is a 60-year-old gentleman, diabetic since last 5 to 6 years. He presented with inferior myocardial infarction, the thrombolized with streptokinase outsides. So echo suggestive of inferior basal and the posterior lateral wall hypokinesia. Ejection fraction is 40%. Came for angiography. The coronary angiography shows the dominant right coronary artery. The distal right coronary artery before the crux showing 80% stenosis. The mid LAD has 80% lesion and the L6 has a mild plaque. So the plan is PTCA to the RCA first, that the culprit vessels, and followed by the LAD. So in this angiogram, we can definitely see there is a 80% lesion before the crux, and the right coronary artery is a dominant. So in the left coronary system, the LAD and the L6 has separate origin. The L6 has a mild plaque in the mid part, and the LAD has a tubular 80% lesion after the first diagonal. So during the we started with the PTCA to the RCA first. The first should taken with the 6 French 3.5 right Judkins, and after the first shoot taken, the wire is not going into the lumens, and so we do the second check. In that we see there is a spiral dissections from the ostium of the right coronary artery up to the mid part of the right coronary, and during that after that dissections, the patient have ST elevations in the ECG as well as hypotensions. So we have to put the patient in inotropes. But the wiring in the true lumen is very difficult. The wire is not going into the true lumens. We attempted 3-4 times, but the wire is landing into the false lumen. As we can't take the antigrade injections because there is a chances of propagations into the chances of propagation of dissections to the distally. Finally, the wires went into the PDA, and I did the stenting at the distal RCA, the sirolimus eluting stent 3 into 24. In the mid part, I taken a 3.5 into 24 millimeter sirolimus eluting stent. In osteoproximal part also, I take a 3.5 into 24 millimeter sirolimus eluting stent, and after that I did a overlapping balloon dilatations at stents, and osteal flaring is done with 4/8 balloon, NC balloon. Okay. So the final shoot is there is a TME3 flow in distal RCA. There is no extravasation or residual dissection. So there is no retrograde dissection of aorta also. So whenever there is a dissection, we have to keep the wire in the true lumen. If the wire is in not true lumen, then we have to attempt antigrade wiring with a spring coil wire. If it is not passing, then we can use the IVAS to confirm the luminal positions. If the wire is not going into the true lumen, then we can consider the another method such as antigrade dissection re-entry or retrograde wiring for laterals or subintimal tracking with re-entry into the true lumens. If this is not happening and the patient is crashing or landing into the shock, then we have to go with IBP or any mechanical circulatory support. If the dissection is the smaller one, less than lumen area less than 50%, then we can go with conservative management. Or if there's a left main dissections, then we can go with a CAVG straightforward. If the wire is in the true lumen and there is a TIMI3 flow, then we can definitely go with stenting. We can use IVUS if to check the size of the stent. If there is a residual intramural hematoma, then we can use cutting balloon to release the hematoma. So take home message from this case, always do the coaxial alignment of the guides, whatever we use. The guide induced acute vessel closure or dissection is uncommon, but whenever it happens, it can land up into the catastrophic situations. In case of dissection, whenever possible, IVUS can be used for identification of true lumen. It easily do the wiring for dissected area. Wiring in the true lumen is a key important area. For entry in the true lumen, point the wire to the inner curve or the myocardial aspect of the artery. And the catheter-induced coronary dissection is preventable if hardware can choose properly or manipulated properly. If it happens, then be prepared and treat them immediately. Thank you.
Dr. Rao, that was a very good save. I think it was a dominant big right coronary artery, and
Yes,
you
sir.
had a dissection which was rapidly spreading forward. So if you had not acted so quickly, probably the RCA would have troubled you. Who likes to put wires? Whenever I would probably do the same way, the way you did. Put a wire, check with IVUS whether you're in the true lumen or a false lumen. If you are in the true lumen, I think your job is very easy. Like you can just put a stent and get out. But if you're in the false lumen, probably you need to put another wire. So when people who do not have IVUS, I go to some peripheral centers also, and there once it happens, so we put wires wherever it loops and goes. So we had two wires. Presumably one was in the false lumen and one was in the true lumen. So have two wires, and then you can afford to balloon inflate. If after balloon inflation, your next picture shows flows are truncated or stopped, then you know that your balloon was inflated in the false lumen. If it is inflated in the true lumen, you would continue to see a forward flow. But let's hear from Dr. Prabhakar what he would do to decide which is the correct lumen. I mean, Prabhakar will probably go ahead and ahead of IVUS and probably show something new.
No, sir. Actually, I don't think you'll have the luxury of IVUS in smaller centers, like you say. And there are a lot of labs which use an IVUS. They get the IVUS whenever they want for a case, because they don't invest in an IVUS and keep it standby in smaller centers, which do about 150 cases per month. So most of the centers I've seen, you want an IVUS, you have to order for it. Now, in this particular case, he's entering into the false lumen. He's getting stuck. Sensibly, he's not been over giving the contrast. And the other point is, your second wire went all the way down, so clearly showing that it has happened, whether you are inside or outside. All your techniques are fine, but I think the other thing is, if you are in the false lumen, you notice that you are there in the middle and it doesn't go at that point. I still remember, I think a couple of months back, Dr. Sirish had mentioned some other technique wherein he said, leave that wire in place, take another wire and go away from this. So it is away from that, you know that that is possibly there. So that is another way of looking at it. And this wire in the false lumen is helpful. In fact, after that meeting, I actually had a case with the similar problems. So proximally, when I was trying to cross the lesion, it was tight 90-95% stenosis. It dissected. And whenever I tried to enter, it was getting into the false lumen, getting stuck. So I left that wire in place, got a second wire, and that goes in a different direction. You're more or less knowing that it is happening. But this method, what he describes with the false trial and error method, if you don't have it, keep both wires, get both wires down, see which one, inflate in this, inflate in that, and then you know which is correct. I think that's something new, sir. Learn something new from that.
Dr. Prabhakar, right or wrong, can tell us, or we can ask Dr. Girish also to contribute. But I would probably put 2 wires, then do balloon inflation and see. That might help us to decide which is a true lumen and which is a false lumen. And then you put a stent in the correct lumen and expand. I would still not remove the false lumen wire even at this stage, because that anxiety is always there, whether you're in a true lumen or a false lumen, unless you have IVUS or OCT. I think OCT would be a risky business, because to get a correct good contrast or good image, you have to inject, and that injection can worsen your dissection. So I would probably feel that IVUS is a better tool to decide whether you're in the correct lumen or a false lumen. The reason why I'm saying the false lumen wire can stay there even if you put a stent is only because, suppose inadvertently you put a stent in the false lumen, you have a wire which is probably in the true lumen, and you can still salvage the vessel. So, I mean, I'm not saying it's a very strong necessity, but I would probably feel it's just safe, especially if you're a single operator, especially if you are in a smaller town, and especially if you do not have an imaging.
I agree with you, sir. But if you're putting 3 stents and then post-dilating, I think the wire may get entrapped. Very true. Till you probably stent them before post-dilation, I think we need to get the other wire out. Another suggestion, the problem for extension of dissection is repeated injections. I think the minute somebody finds the dissection, they should stop injecting and try and pass a wire wherever it goes, and then take a micro catheter and then inject it on that wire and see distally whether there is blood coming or not. If you have gone through the wire, put a micro catheter on IVUS very safely. People don't have an IVUS. The next best thing is either the balloon which is not over the wire, the old world balloon, or use a micro catheter, suck the blood. If it comes out, then inject through it and see if you're in the true lumen. It doesn't matter from proximal where you have gone in the side branch. That is my one tip to people who work in peripheries without much tools with them.
So, Girish, sir, have you had an opportunity for a re-entry through the dissection wherein you have not been able to grow antegrade directly into the lumen?
Many a times, especially if it is RCA, I am not so finicky because we don't lose much branches in RCA. So my goal is quickly, especially if you have such large dominant RCA and if it starts shutting down, I just want to make sure that distally I am there before the distal bifurcation. I just don't want to go to PDA or PLB. I want to re-enter much before that so that I preserve both the distal branches. And then I don't care. I know I would do a balloon at least and establish the flow and see. And if I'm convinced, I would stent it. At times, even when I'm not sure that I'm in absolutely true lumen, I would still think I've gone from true, false, and eventually into true. I would stent it. Another thing, occasionally, if I'm very certain, I would stent the first one first, the proximal one first, because here the dissection is at just after the origin. if you go on fixing the distal, you are only increasing the stent length. If you just stent the osteoproximate with some 38 or 28, and then you have enough time to think and do.
There are, I think, some connectivity problems. Girish, sir?
Audible?
Yes, sir. Now
You're back now, sir.
Sorry, what I was saying is, I think stenting the entry point is more important than the stenting the distal area. I mean, distal exit point of the dissection. You don't always have to start from the distal most part. The way we treat aortic dissection, if we treat even aortic, coronary dissections, we will have enough piece to plan. So if you're certain that distally your wire is in the true lumen, stent the osteoproximal region, then breathe easy, inject. You have enough time to plan further.
So, Dr. Girish, what is the plan? I mean, suppose you feel your wire is in the correct lumen distally,
Right.
and you decide to stent the site where the dissection is initiated.
Right, sir. Osteoproximal.
And how much length you want to stent?
I just take the longest that is available, 28 or 38. Because what happens to position 3 stents, they go on taking multiple injections. I think that would cause more harm, more hemodynamic instability, because the proximal flow would not be still great, although we have stented the distal. So I take the longest possible, 38 or 48, but make sure from the osteoproximal side we start stenting, and I'm sure the distal flow would be maintained.
No, ultimately the final result will be same that Dr. Rahul achieved.
But he would have taken multiple injections again, and they probably many a times you don't have to put 3 stents. Just seal the osteoproximal, and then the dissection flap would heal itself, sir. If you do an IVS and see, at the end of the stent, there is no dissection flap.
In fact, that is the advantage of stenting the site of dissection. If you seal that probably, and a sizable length, say about 15 millimeters beyond the ostium, I think the blood getting into the false lumen will stop. And,
absolutely.
And then I think you're quite safe.
What happens to the hematoma, sir? Intramural hematoma that is going to be there because of the dissection. What happens to that? Do we release that, or you have to?
If there is a TIMI3 flow, you can always, if it is not a occlusive dissection, if there's a good TIMI3 flow, less than 50% narrowing, you can do it. If you think that there is significant hematoma, you can just use a cutting balloon, just go at 4-6 atmosphere, and just release that pressure in the wall so that it does not propagate into one of the distal branches. And then image it.
And do you stent that after the cutting balloon?
No, many of the times I don't, because it's just, 4 atmosphere, it is decongesting that. So I don't.
Well, Dr. Girish, use a balloon with a blade, and that is going to cut the intima, and that is how the hematoma is going to be relieved. I would probably feel that we need to stent, because we have clearly produced some intimal injury or damage, and the only way it will heal is sort of
covering with the stent. But sir, if you're doing CTOs, very often we realize that CTO is stented proximal to mid, and there is a big hematoma that's gone till the distal RCA. We oftentimes, just go do a cutting balloon, release it, and they do very, very well. I mean, this is my experience, but you are an expert too. Oftentimes we can avoid, I think, sir.
I think if you're going to do that, you'll have to image it and make sure that things are all right. The extent of dissection, and I think without that, I don't think it's safe to just leave it alone. If you don't have Imaging, I think it might be safer to stent it.
Well, if there is a subocclusive 50% hematoma, why do we have to stent it at all? We know that hematoma is going to be reabsorbed. If it's not causing you acute ischemia, I don't think hematomas need to be treated.
You are cutting it with a cutting balloon, blade of the cutting balloon.
That's only if it is causing, less than TIMI3 flow, I would probably do a cutting balloon. If there's a TIMI3 flow, I won't use a balloon to cut and decongest.
So do I take it that if you have, let's say 60-70% with probably less than TIMI3 flow, you used a cutting balloon and
Yes.
you use an imaging and then decide whether you want to stent it, or if you don't have imaging, like
I won't. I know that it's a very healthy segment. Before in the first angiogram, if I know how healthy the vessel segment is, if I've just made a small nick to decongest it, I don't think I'm going to stent it. So that's my policy, because it will heal anyway. Oftentimes you're doing drug-eluting balloons, okay? We are using a cutting balloon in a very fibrotic distal vessel. Then finally, I do a drug-eluting balloon and coming back, not stenting. And they do well. So why in a healthy vessel where I've just made a cut, I should scaffold it with a metal?
Well, I think as an argument, you may have questions for everybody, but I would probably feel if you cut an intima with a cutting balloon, I would probably want to stent that. I would feel very unsafe.
I agree. I mean, we may disagree to agree, sir, but I may not stent till the distal. He put in 3 stents in apparently lesion which probably didn't need that much stent. That's an option, what I'm saying. If you're confident, if you're in a big lab where you at your disposal you have many things, you can do what I said. But the safest option is stent everything. That's much safer.
All right, Dr. Rahul, your case has generated tremendous sort of variations.
So I have one question. If the second wire is not going easily into the true lumen, or it's taking too much time, then what are the tips to put in the true lumens if the IVUS is not there?
No, I think my feeling, but let's ask Dr. Prabhakar as well as Dr. Girish. You put a second wire and try and stay away from the first wire. That is how you would probably differentiate that you are not in the lumen in which the first wire has gone. Now, you probably need a little bit of luck, and if you have no imaging, I think it's still going to be a bit of a challenge. But many times you would see on the screen that the 2 wires are away from each other, and you can sort of make out that they are not in the same channel.
I think we discussed that in the beginning itself, like the different techniques. Dr. Sirish had mentioned one, then I said keep one wire and put another wire. Otherwise, try to re-enter. And the other technique which Dr. Girish sir was telling was get a microcatheter inside and inject and see where it is. In fact, that also helps. The microcatheter, when you inject and you see that you are in a hematoma, that gives you a guide about where the lumen is, the rest of the lumen is. So you look at different angles and try to stay away from this. You're going to probably enter that area also. So I think it's like there's an element of luck also involved. And seriously, if nothing works, get into the vessel, get into the true lumen, because it's more important to establish the flow there and get the vessel all right, because your patient had a significant hemodynamic compromise. So I think that should be possible there.
No, but did you ever come out without putting a stent for a dissection of this nature?
You have to stent it, so definitely stent it.
I mean, you can't sleep that night, if you don't stent.
Especially in this case,
again means that you have to find a true lumen. Your wire has to find a true lumen. So put wire wherever it goes. Don't be very aggressive, and let the wire sort of make a forward inching or maybe millimetering. And if it goes nicely into the distality, you're probably in the correct room. But this is, I guess,
Right.
a lot of, I mean, you need a good luck on that day, you know.
Very true, sir. But I also believe, Rahul, you will have to make a conscious effort to go into the true lumen. As sir said, the first wire, you leave it wherever it is and do not force it to enter into a distal branch. If it goes smoothly without resistance, your tactile sensation will tell you whether you are needing much force to advance it. Please don't. You leave it where it is. Don't take too many injections. Then take another wire and consciously move away from this into the other segment. So please load the image that you had with the first injection. Keep reviewing that image and try and go the other side. If you're not reaching any further, then it is like you're into a CTO segment. Now you start working like that. Take a little stiffer wire and make different kind of bends. Like, Pilot 201 is a good to go through multiple intimal layers. So use a Pilot 200 and penetrate and re-enter and use a microcatheter. That's how I would look at it. I learned a new trick recently from one of the US operator who had come. He would put the microcatheter into the distal vessel, take out the wire, and connect the pressure catheter to this. If it is in the lumen, it shows pressure waves. Surprisingly and consistently, it shows. So it's a great learning.
How did you learn from this foreign operator? I mean,
if your
obviously, when he was with you, somebody created this subintimal passage, right?
No, sir. We were doing a CTO workshop. So if you normally what people do is take the microcatheter to the distal vessel and inject and see whether in true lumen. What the gentleman says is, before you are tempted to inject, just connect the blood pressure, whatever we have for the multi-fold, manifold, whatever the pressure is connected, remove it and connect to end of the microcatheter. If you're in true lumen, it does show pressure, probably, systolic of about 40 and diastolic of 20. Very small pulse pressure, but it definitely shows a pressure wave.
It would show waveform.
So kindly, waveform.
In contrast, if you're in the false lumen, which has got a dead end at the distance.
Just a flat line. It's a flat line. So at least you will, you would not extend the false lumen by injecting it.
I think this injection is a very, very important factor. Like to check whether you're in the correct, your wire is in the correct lumen or a false lumen, you keep injecting, and that could worsen the dissection, rapidly progressive distal. So I think sort of just fluoro and keep the wire tip away from the first wire, which is somewhere. And I mean, we don't know whether first wire is in the correct lumen or the second wire that you're trying to put is in the correct lumen. So stay away, be gentle, don't push strong. And if it goes distally, you're lucky on that day.
Thank you, sir.
All right. Thank you, Dr. Rahul, for this interesting case. Dr. Prabhakar is already clapping for your nice presentation.
Great
so, Mr. Ravi will go to the next presenter.
Sir, very unfortunate that Dr. Suchit has struck into the heavy rain and he is unable to reach his home. But that's the reason, sir. I think we'll miss his presentations at this time.
So I would present.
Yes, sir. No, sir. Only we had two speakers this time.
No, I have a presentation.
Yes, sir. Yes.
Present.
Yes.
Manish, can we get to the presentation? Just give me a second.
Sure, sir. Sure.
अपना presentation लाना चालू करो. So quick. There's no time. They're waiting for you. Cases for the left main distality. Actually, there are two cases. I thought we will see them together so that we can see how they can be different from each other. This is one case where you have a left main. The left main looks reasonably good till the bifurcation. The LAD is going up and very small compared to the circumflex, which is a dominant circulation. So some disease in the proximal circumflex, but doesn't appear more than about 40%. And the OM1, or ramus, you can call it, it sort of branches into two important vessels distally and is showing an important narrowing at the origin and a few meters away. In the other case, similar three lesions, but the LAD is clearly critical at this point, and the ramus is also showing an important proximal lesion with a dominant circumflex. So this is the scene. I think both the gentlemen had a preserved ventricular function. So the issue would be one stent to LAD, one stent to ramus, question mark, stent to circumflex. So what will you do? Will FFR help? I think certainly FFR to this vessel would be an important addition, which will tell you, yes, it needs to be done or need not be done. So in these two cases, here the FFR is negative circumflex, while in this case, FFR is positive circumflex. So in this case, we are probably going to stent the circumflex too. These lesions, which look about 30–40%, are giving positive FFR, and probably need to address, probably need 3 stents. So how will you do it? I think if you're just needing 2 stents, probably put the first stent left main to LAD. Now this is again a disputable issue whether ostial LAD should be stented from left main, or you can start your stent just at the ostium of LAD. I would generally feel that ostium of LAD stent placement may or may not be perfect. Will probably have no metal proximal to the beginning of the lesion. So I would get a few millimeters into the left main, and then after stenting this, take another stent here and do a T end protrusion. Like you can see here, the stent to ramus is protruding backwards. And we don't have to do anything to circumflex since FFR is negative, and you don't pinch the circumflex with the stent here. In this case, in the second case, the plan was to stent the LAD first, then the second stent goes from left main to circumflex, and then the fate of the third vessel, the ramus, which is actually branching into these two, would be dependent on how the ostium is and how the flows are. Probably this would need a T and protrusion. So you have a lesion here and a lesion somewhere here. I just want you to remember, because some people, once you wire this, if the wire goes here, they think stenting up to this may be adequate. However, it makes a lot of sense to stent the lesion here. This is again running a reasonable length in the distal. So this is the decay crush between LAD and left main circumflex, and tap to the OM1. So so now we are going with the first case. So we have a stent in LAD, and then through the stent, a wire is placed into the ramus. We a balloon to the ramus, and then do a tap. You can see how we do a tap. The wire in the circumflex is kept, but FFR was negative in this case. So stent is not a consideration to the circumflex. So once you finish 2 stents, one to LAD and one to the ramus, you still need to stretch the portion of the stent in the distality of the left main. And this is what is done here. So, so this is the way FFR is negative here, doesn't need a stent to circumflex. So first stent is placed from left main to LAD, and then a tap to the ramus, and you have this kind of result, which shows good flows to LAD, good flows to ramus. And dominant circumflex, mildly diseased, would probably need aggressive medical management. So in case 2, as we started doing this case, we had a problem. This is the FFR in the circumflex. You can see the circumflex has big dominant circulation, and FFR is 0.76, which is an abnormal FFR. So this also needed a stent. So how do you plan it? Multiple options. I mean, every angioplaster would probably think in a different fashion. We did an IVUS, and the IVUS showed a problem at this area. So probably the circumflex stent needed to come up to this point. And then these were the multiple styles in which you can do these stenting. So decay crush between LAD and the left main circumflex stent. Or you could do both as a mini crush. You can do the ramus or OM1 as a provisional and may not stent if you think it is not damaged with the stent. And this would be no stent to the middle branch. Or you can do a tap to LAD. First stent is left main to circumflex. A tap to OM first and tap to LAD afterwards. Now this sequence is very important, because if you put the first stent here and you stent, do a tap to LAD, you probably may not be able to take another stent to the Ramus or OM1. So always do this one first and the proximal one later. So we sort of planned this case, and we put the stent in the LAD after pre-dilatation, and we are trying to actually crush the back end of the stent. And as we were doing this, the balloon slipped forward, and as expected, once this has happened, we lost flow in the OM1 or REMS. There was ST elevation. Patient fortunately was hemodynamically stable. However, our problem was we were doing this case as a live case. And there was a sort of multiple people advising us what to do, what not to do, and so on. So under these kind of circumstances, it's very important to keep your cool. And what would you do to get this, get a wire into the Ramus or OM1? So we chose cross 100. I think this is a very nice slippery wire. It's to some extent a secure wire, but it has a very nice hydrophilic coating, and it went in easily through the vessel which was closed. So you can see a closed vessel, and the moment the wire goes, you can start seeing both these vessels which were not filling here. So now, since flows are established, earlier plan was to do DK crush between LAD and left main circumflex stent. The left main and circumflex stent, many people feel we should always have left main to LAD stent, and circ stent should be secondary stent or a side branch stent. But since this was a dominant vessel, we thought we would put the stent towards circumflex from left main and use LAD as a side branch. So because we had lost flow into the OM1 or Ramus branch, and we had already put a stent in the LAD, the second stent went towards this branch. So one here, second one here, and then the third here. So this was done as a mini crush. And let us see the subsequent courses. So here you can see the LAD stent was deployed first. The second stent was deployed in the OM1, and the third one went from left main to circumflex. We do a pot. Now pot, many people feel is for left main, but pot I feel will create a sort of an angle between the high pressure, bigger balloon and the already deployed stent. So it will create an edge through which the wires can slip it easily. So once you do a pot up to LAD, then you wire that vessel. Then you do pot up to OM1 and you wire the OM1. You could have also done this one first, pot up to OM, but LAD is always an anxiety in everybody's mind. So we like LAD flows to be quite good. So always, in this case, the LAD was wired first. The OM1 was wired next. And so we have all three wires in position, all three stents in position. So the first case was done like this, circumflex and OM1, and the second one was between circumflex and LAD. And this is the final pictures that we are seeing. The flows are good, the stents are looking very nice. One could do a sort of post-stent IVUS to make sure that the stent are well deployed. But yes, I think when you're doing this kind of case, you're always going to be using high pressure inflations and pushing the stent into the vessel wall. If you don't do it, I think the future of this kind of fancy stenting is probably not going to be good. So what we had planned is LED stent number 1, then decay crush at this point, and then left main to circumflex stent, and then a tap towards the OM1. Instead, we had to do a mini crush after putting LED stent, the Ramus stent, and the third stent here as a mini crush, and that is how we salvage the situation. Now we go to so this is the first case that we discussed. When we did LED stent first, lost flow in the circumflex, like there are no flows. And finally, we did a mini crush between LED and the main stent going towards circumflex, and mini crush between the OM1 and the stent going to circumflex. So this is the final thing. Stent 1 in LED, stent 2 in Ramus, and then stent here, and then KISS, and that is how resolve this. So this is a pre, and this is a post, and as you saw in the previous slide, this is the way the stents are placed, and it's a mini crush. I would feel mini crush, many people don't like it, but I think in difficult cases, doing a decay crush and all take a lot of time, a little bit of an anxiety if you run into no flow situation. Crush is side branch stent first, flows continuous, and you can do a final kiss whenever you're ready. And this is the second case. You saw the first case, how it was done. And the second case, we planned like this. First time going from left main to LAD, and then you address the Ramus. So the take-home message from these two cases is respect the side branch. So always wire the side branch. In this case, we are actually, when we put a stent in LAD, actually this was just the beginning, and we had not even come ahead, but we had not wired this. So when we are doing a pot, the balloon, instead of stopping here, came a little bit ahead, and we lost flow in the OM. So bifurcation stent strategy: secure the important side branches stent first. High pressure deployment and imaging are strongly recommended. So this is how the two cases were done. One got complex and we had to resolve that, and the other one was pretty straightforward. So any comments, anyone? Dr. Prabhakar, Dr. Girish?
Again, losing a side branch totally and entering it requires a lot of imaging, looking at your older images, because this not wiring smaller diagonals and smaller OMs, which we don't plan to stent. You really need a good wiring technique and get a good curve. In this case, I think probably one of your advantages was that it was more or less straight from the left main OM. So I think the entry was easy. So
Very true.
2
I
weeks
mean, the
ago,
wiring was easy. You know, it
was
was
easy, actually.
left plane, and just as left plane most of the time enters LED, in this case, the wire would probably enter the rims.
So recently I had a case similar, but I respected the side branch, like you said. It was a just less than 2 mm sized diagonal. So I was tenting the LED. Since the diagonal was looking quite big, I thought, okay, let's wire it, and actually, there was some lesion there. So I did a probe of about 1.5 mm, just did it, pre-dilated the LED, and then once I got the LED stent, I removed the wire. It was looking good. But once I did the post-dilatation, that diagonal totally disappeared. Patient started becoming symptomatic. But I had a wire that had already gone inside, and I knew where to look for it. And I did a pot there just deliberately, trying to change the anatomy, and then got a wire inside. So sometimes that helps. So in your case, I think it went reverse. The pot that you tried to do actually closed the vessel. So
Yes.
I got the stent inside, and once the stent was there, initially flow was very good. But once I did the post-dilatation, the diagonal disappeared and patient became symptomatic. But I still managed to get inside and did a POBA, very small balloon, and still did a kissing there to get out, because I didn't want the LED stent to be deformed.
So,
Yes, sir.
So, Dr. Prabhakar, in your case, why did you remove before doing the final dilatation?
That's a good question. I was
I
asking
think
that later
many
after.
people, including myself, I used to hear, yes. So only when you do your many of us feel that the side branch wire will get jammed between the main branch stent and the vessel wall. But it hardly ever happens. If it does happen, just get a small balloon, give a little support, and pull back the side branch wire, which is outside the stent, along with the balloon, and it comes out.
Yeah, I that was exactly my thought. Since the flow was good, actually, it was 3 flow, and I was only doing a post-dilatation, I thought, okay, everything's going to be fine, and it came out. And then the same fear was there inside me. Going to give a high pressure inflation, the wire gets trapped, I'm going to be having more trouble. But luckily, I was able to cross it despite the angulation of the diagonal, able to cross it. I think that was it was quite challenging at that point immediately. But once you've done it, then okay, you're comfortable. You don't sweat at that point. But like you said, I think that fear is always there that the branch get trapped. I think that mindset has to come out, sir. I think once you balloon support.
Yeah, actually, it's very, very rare that a high pressure inflation of a balloon or the main branch stent will jam the exit of the side branch wire. So be very, very fearless. The main branch stent can have a good diameter balloon, go high pressure. And even if you go high pressure, your side branch wire will easily come out. If you're using an O wire, I think we all understand the meaning of O wire. O is Oxford. I think that's some little bit of a worry. So don't trap O wires in the side branch. If I'm little constrained on the wires, I probably use the O wire to the main branch and the box wire to the side branch if you're going to pull it out after high pressure.
I think the problem is, I think, the mindset. You go to a conference, you see all these trapped wires, they don't come out, and they do all these gimmicks, and that sticks to your mind. These complication sessions are sometimes a little scary. And what is your choice of wire in the side branch, sir, generally?
Oh, side branch wire, I like to take a hydrophilic wire. I would take cross 100 or run through hypercoat. These are the wire I take for the side branch.
No, your initial choice before you had taken a cross 100 after the vessel closed and did it. But if you're doing it initially, when you're going to jail it, at that point, you still take a cross 100, sir?
No. I would take, but hydrophilic wire, because the contrast or the time spent is much longer if you're taking regular wire. Hydrophilic wire will just walk through all these difficult angles.
So I think when it get trapped, I've always found the cyan blue to be a good wire. When you jail it, it comes out quite well. That's my experience, because when I once did it with a I think it was a BMW, and I got stuck, and after that I kind of fixed with cyan blue. So side branch is going to be a N cyan blue. The side branch wire is the N wire always.
Certainly. Dr. Girish, any of your comments?
No comments, sir, presently. And Dr. Girish sir has called me. He is actually, because of network, he disconnected.
Okay.
Yes.
Sir,
Dr. Rahul, anything from you or any questions?
Sir, in this case, when you had the OM, the second case, when you had the OM getting closed, the OM was closed, and
Yes.
getting into the wire, how difficult was it getting into the OM again, sir?
No, it was very easy, because we had put only an LED stand that time. So
You did not have to cross through anything.
yeah, I mean, there was no stent in the left main circumflex. So LED stent was coming only to the ostium, so we could easily put a wire in the side branch. So acute closure, I think getting that wire in is never an issue. Always.
So retrospectively thinking, sir, you had wanted to stent the ostium of the ramus also initially. So
Yes.
how about pre-dilating both before stenting the LED?
I mean, you mean
dilate a little bit of the ostium.
Put a wire in LED
and the ramus.
Wire in circumflex. OM.
OM, and probably dilate it a little bit. Even a wire there is enough, because you're not going to cross it.
No, but
this is retrospective.
Our plan was a DK crush on LED, because I thought mini crush for LED is not a very strong news. I mean, after all, it's LED, and so many septal branches come out. So I would probably feel that LED should be respected. And as it is, we were treating the LED as a side branch, and that true mini crush was not a great idea. So it was a DK crush on LED, the plan.
Huge dominant circumflex. So I think that is kind of okay with getting into the circumflex. It's such a big thing. And I think ultimately the results show, and the experience of the operator matters a lot truly in this case. And how you keep your cool and enter the branch that is not visible. And you have to look at your views, make sure that you get the same view, get into the same place. Otherwise, you're not going to get in anywhere. And the hydrophilic wire, yes, that is the key, I think so. That's just going to jump in. So once it gets in a little inside, it just slips inside and gets inside. I think the choice of wire in these cases is very important. Once you've got a wire inside, I think you have all the gadgets to get inside and open up the vessel.
Yeah, once the wire is in correct position, you have time on your side. Like, you can put a balloon, small balloon, just pass it, come out. Don't even inflate. Your flow will start, and that would stabilize ECG, stabilize hemodynamics, and patient will be more comfortable, no pain.
The final result, did you do an IOS run finally, sir?
No, we didn't do in this case.
In this case, because I thought the proximal part of the LED was a little, I think, good enough result ultimately, considering how tricky and difficult it was. Proximal LED, I think, was a little underexpanded, probably. Was looking, so that's why if you're probably IOS, you would have probably post-dilated a little more there into the LED. That's what I thought. But I think the circumflex is the dominant vessel there, and
yes,
very good result with the circumflex. I think huge circumflex, and the strategy of left main to circumflex, I think, makes a lot of sense in this particular case. But I think a lot of lessons learned. Respect the side branch, I think, is the biggest lesson in this particular case.
Absolutely. I mean, we were just trying to crush the back end of the LED stand for DK crush with a balloon, and that actually hurt the flows into the REMS or OM1. I think basically the balloon shouldn't have come beyond LED origin. It could have stayed just up to here and not come down further. I think since it came down, we lost flow and all the.
Very basic questions. Very basic question on this. Your marker, your distal marker in the left main, which you were dilating, so you're trying to create a pot there. Where do you position the distal marker at at the level of the LED, or you just try to go beyond the LED? Because the balloon seems to protruding a little beyond the marker always.
I mean, balloon beyond the marker, though it is there, it is sort of tapering like this. So your marker is at my thumb level, and the balloon beyond the marker is like conical. So it will probably not reach the wall of the vessel.
Now that the reason why I asked is for this has two implications. One is this particular case where you want to do a pot at that point up to the LED, and second, it also has a lot of importance when you try to do a decay crush and try to do a pot initially, and you have to stop at the ostium of the vessel. So you want to do a pot optimally to open up the strut there. That is going to be there. You go beyond, it doesn't work. So I think the marker, the distal marker, is going to be very important there to position it exactly where you want. So in this case, like you said, I think it slipped a little bit.
Very true, yes.
Rahul, anything you want to ask? Continue anything?
Oh, good lessons from both of you.
You're listening to the master here with how he gets into trouble and opens up, especially in a live case. Imagine that.
Yes.
And his biggest distraction was the advice from the floor.
Yeah. Actually, and you know, the experts were giving, as I remember correctly, about at least two to three different variations how I should proceed. Sort of, I had to keep everything shut, my ears, and just concentrate on getting the wire in the vessel. I think once that happened, I think everything was very smooth. So, Mr. Ravi, I think if you have no cases, maybe we should close today's session.
Yes, sure, sir. So once again, from behalf of Emcure, I would like to thanks to our first speaker, Dr. Rahul Trimuke, sir, and and also one of very unique and interesting case presentation by Dr. Shilis himself, and that has definitely benefit to all our delegates who joined today. So once again, thank you, sir, and also thanks to Dr. Prabhakar, sir. And always sir is ready whenever we inform about no thrombosis, sir. Please always give his time, and we are really grateful, sir. From behalf of Emcure, we are very grateful and thankful to you, sir, for providing a valuable time to join this, the no thrombosis program, and giving a lot of insights to all our delegates, sir. And also thanks to Dr. Girish, sir. He is actually who is also a part of moderator. Once again, thanks to all our moderator and also Dr.
Ravi, from all of us, thanks Emcure for bringing us together again and again and giving us an opportunity to interact and share each other's important cases. I'm not saying complex cases or complicated cases, but important cases. Like I would like to see how Dr. Prabhakar does bifurcation, or maybe he would like to know how others do bifurcation. And that is the big learning for all of us. I think the beauty of coronary anatomy is no two vessels are identical. I showed you today's two cases. I mean, intentionally shown together because they look pretty close to each other, and we did it in different fashion. But it's very unusual to get two cases which are so close to each other. Thank you indeed.
Thank you, sir. Thank you so much, sir.
Yeah. Thank you very much, sir. Thank you, Prabhakar, sir.
Good night, Rahul. Good case.
Yeah, good night.
Good night, sir.
Good night, everybody.
Good night, sir.
Good night.